going on in my square of the universe over here. But really great to see Lawrence and everyone else here as well. So this is our men's supper club that we usually involve supper, but feel free to grab a beer and grab some snacks and whatever you'd like. And we're in for a real treat. I'm very excited to have so many septimi on one phone call. So without further ado, I will turn it over to my good friend, Daniel Septimus, Chief Executive Officer of Shalom Austin, to kick us off here.
Thanks, Ian. Really appreciate it and for doing the welcome. And I just want to thank all of you for being on here and for being such amazing supporters of our community and our organization. Without you, we wouldn't be where we are today and be able to gather like this. So thank you. And just a couple of updates before I introduce Dr. Ed Septimus, aka my dad. But I want to say that after 3 months of closing, just over 3 months, we reopened the JCC and specifically the sports and fitness complex on Monday. And as we were opening, we had 1,000 reservations made to enter the complex. And it's been pretty smooth so far with our reopening. We're doing it in stages. We're going to start camp at a much smaller scale in a very different way for our early childhood program and for our school-age children on July 6th. So if you know anyone who might be interested, please sign them up. Of course, we're going to be following the highest safety protocols as we do it, but so far so good. And we're excited to see people again. It's been really nice. Our adult program staff and our Jewish family service staff have been working really hard during this crisis to reach as many people as possible, especially those who are most isolated. As a matter of fact, we have a mitzvah knitting group who works together on a weekly basis to knit things for those in need, especially as the winter season comes. And our JFS team delivered activity kits for their homebound seniors so that they could continue to knit together and to be together in that sense as they gather over the Zoom platform. And we also are delivering kits to all of our homebound seniors to make sure that they are connected and have things to do while at home. I'm actually really proud to say that we just received a city grant for $20,000 that we're able to give to 10 families, so $2,000 each, which is nearly tripling our emergency financial assistance budget, which actually, thanks to the generosity of many of you on this and many others in our community, we have really been able to increase the amount of money that we can give out in emergency financial assistance. We have had an uptick and we anticipate that that will continue. So thank you. And overall, our community response fund in response to COVID-19, we've raised well over $300,000 to over $200,000 of which is unrestricted. And we're going to be working with our community response fund task force to look at the impact to our institutions, synagogues, organizations, day schools, our overnight camps in the region to see how we can help support them through this crisis, as well as I just mentioned, helping those who are most vulnerable during this time. We're kicking off a match for our YAD, our young adult group, and David Klein is offering a $10,000 match. We actually had someone donate $3,000 already to that match before we're doing our cocktails for COVID kickoff. So we're really proud of that and how YAD is going to play a role in this. And then all of you should have received an invitation that was on behalf of the Jewish Community Relations Council in Dallas to have an opportunity to hear from Governor Abbott in the coming week about the response of the state government to the current crisis. So lots going on and look forward to many more opportunities to interact. So with that, I am proud to introduce my father, Dr. Ed Septimus, who received his medical degree from Baylor College of Medicine. And I have to say Dr. Ed because there's two Dr. Septimuses on this call. But he received his degree from Baylor College of Medicine in Houston in 1972. He went on to complete his postgraduate training in internal medicine and infectious diseases at Baylor College of Medicine in Houston. Dr. Ed Septimus is board certified in both internal medicine and infectious diseases. He was VP of Research and Infectious Diseases, HCA Healthcare, until 2018. And prior to HCA, he was the medical director of infectious diseases and occupational health for the Memorial Hermann Healthcare System in Houston. He has served on the board of directors of the Infectious Diseases Society of America and was on the IDSA Antimicrobial Resistance Committee, the Antimicrobial Stewardship Committee, and the IDSA Quality Measurement Committee. He was the first recipient of the IDSA Annual Clinician Award. And in 2011, he was appointed to the Healthcare Associated Infections Preventable Adverse Events Advisory Panel for the Texas Department of State Health Services. He was awarded the John S. Dunn Sr. Outstanding Teacher Award in 2010, 2011, 2013, and 2014. He's on the FDA Anti-Infective Drug Advisory Group and is co-chair of the NQF Patient Safety Steering Committee. And here, this will make Lawrence Mace happy. He holds a faculty position as a clinical professor at Texas A&M College of Medicine, senior lecturer, Department of Population Medicine for Harvard Medical School, and professor of Distinguished Senior Fellow, School of Public Health at George Mason University. And he's published over 100 articles and chapters. And I'll add that my father also has been very involved in the Jewish community for many years. He was president of Congregation Emmanuel, and he served in leadership capacity in several facets of the Jewish community, including the Jewish Federation of Greater Houston. So with that, we'll turn it over. Thanks for joining us.
Well, I could say thank you for that ordinary welcome, but that was quite nice. Thank you, Daniel. You know, when I accepted this about 2-3 weeks ago, I didn't predict what was going to happen in the last 2 weeks to COVID. I don't think Austin, in fact, I know Austin is not impacted quite the same way that Houston has been in the last 2 weeks, but I think we can say that across Texas, the incidence of disease has gone up over the last 2 to 3 weeks. And we can come back and talk a little bit about what that means and what it doesn't mean. What I hope to do this evening is to take the fear out of this pandemic by giving you some common sense knowledge by which you can carry on your day-to-day work in Austin. Because I think it's really important to be able to balance what we know about the disease, what prudent things we can do to prevent transmission, and how we can get along with our daily lives without putting our highest risk individuals at risk. So coronavirus, or it's a zoonotic disease, and by a zoonotic disease we mean it's infection that's transmitted from animals. And I'm sure most of you know that the origin of this virus is probably in bats. I'm sure you've all heard of SARS, which was present in 2002, 2003. The intermediate host for SARS was a funny animal called the civet. You've probably all heard of MERS, which, by the way, is still endemic in the Middle East. And that intermediate host happens to be the camel. We're not exactly sure what the intermediate host is for COVID. And the official name for COVID, by the way, is SARS-CoV-2. And the reason it's named SARS-CoV-2 is that when you do the genomics of the virus, it's very close to the original SARS. But as I'll explain to you in a moment, it acts very differently than the original SARS virus did. Our current knowledge has been incredibly exponential in the last 2 or 3 months. From a virus that we were not very familiar with, the learning curve has been incredibly steep, and we know a lot more about this disease than we did 3 months ago, because at the end of our conversation tonight, I want you to leave with some cautious optimism that we can live with this virus and how we can do that. Because I want you to leave feeling a little bit better about things than perhaps how you came. So what do we know about this particular virus? First of all, we know it's a little bit more contagious than influenza. There's a term that many of you may have read about in the paper called reproductive number. And that means that if I'm in a room and I have a number of people in the room that have close contact with me, how many of them will become infected? So probably one of the most contagious viruses out there is measles, which is why we have had these outbreaks of measles in the United States, primarily due to lower immunization rates. Measles will infect up to 12 to 18 people with close contact. Influenza is about 1.5. And for this particular virus, it's probably somewhere between 2.5 to 4 people. What that means is it's a little bit more contagious than influenza, but not nearly as contagious as measles. Another term that I want to point out, which is important as we move forward, is something called herd immunity. What percentage of the population has to be immune for us to prevent outbreaks? So in a highly contagious virus like measles, the herd immunity to prevent outbreaks needs to be above 95% because it's so contagious. And that's why as soon as that immunization rate drops a little bit and influenza gets introduced into a community, you get these outbreaks. Now, this virus is not nearly as contagious, and it's been estimated by modeling and by epidemiologists that the herd immunity for this virus needs to be somewhere around 70%. Now, why is that number so important? Where are we right now in terms of what percentage of the population is actually immune to this virus? And probably, as you know, the biggest epicenter for this virus has been New York City. And there have been some very nice epidemiological, serological studies now done in New York, San Jose, California, which is another one of the early hotspots. And it looks like in New York City, which is, of course, the highest, it's about 20% of the population has been infected, even though they've had so many cases. That's far short of herd immunity. Now, what is it like in Texas? And probably the best number we can look at in Texas, what percentage of patients who are getting tested are positive? It used to be around 2 or 3%, and it's now up to about 7%. So that'll give you an idea that we're not going to get to herd immunity anytime soon, which is why I'm saying we need to learn to live with this particular disease and try to do it as safely as we possibly can. The next thing that I'd like to sort of put better perspective is what's the case fatality rate? In other words, what percentage of people who get this disease are actually going to die? Because the initial numbers were fairly high-ish. And it turns out now that we know there's a fair percentage of the population who get this virus either have no symptoms or have very minimal symptoms. So 80+% of people have minimal or no symptoms at all. It's only about 5+% that are sick enough to actually get into the hospital. So when these big seroprevalence studies are done, where we look for antibodies in the general population, it appears that the case fatality rate, especially if you're less than age 60 or 65, is probably in the range of anywhere from 0.2 to 0.5%. Influenza is around 0.1 to 0.2%. So in the general population, this is a little bit more lethal, okay? But it's not the kind of numbers that you heard of before, except in the high-risk populations, which I'll get to in just a moment. Let me contrast that to SARS, okay, which is another coronavirus, okay? With SARS, if you're age 60, the risk of dying from SARS was 25%, 25%. And if you were over age 75, 70% of people who got SARS died. I just want to contrast that to another very close virus. Now, what about the higher risk groups for COVID? So if you're age 60 to 65, it's about 4 or 5%. If you're in the 70 to 75% range, it goes up to around 8 to 9%. And it really doesn't go up to really double digits unless you're over age 80 or you have a number of underlying medical problems, especially heart disease and diabetes in particular, or you're immunosuppressed. So that'll give you a contrast as to how we rate this virus in terms of how many people are going to die from it. The problem is that nobody in this country has immunity to the virus, which is why you're seeing so many cases that are out there. But I want to kind of allay your fears. It's not as lethal as initially reported unless you're in the high-risk group, as I just mentioned before. The next thing, which I think is important, what about children? Okay, I know that Daniel has the responsibility of opening up the J and other things on campus. It turns out that if your child is less than age 5, this virus is actually milder than it is flu. Flu is much more serious in children aged less 5 than this particular virus is. Now, you're probably all aware of another syndrome which has recently been in the news, this inflammatory disease, which looks like Kawasaki's. It's actually present in a very small percentage of pediatrics, but pediatrics tend to manage this virus very, very well, except for those rare patients that end up getting this Kawasaki-like syndrome. The peak age group for that's about 8 or 9, so it's a little bit older than traditional Kawasaki's. Now, what about the spread of this disease? How do you get it? I think most of you probably heard this till you're blue in the face, that it's primarily by droplets, and that's true. That's why we try to practice social distancing, because most droplets don't travel more than about 3 or 4 feet. So you've heard the term 6 feet. There may be a small percentage who may be singing, shouting, sneezing, and coughing that may dispel droplets a little bit farther, which is, we'll come back and talk about masking in just a little while. And so what do we consider a close contact? So one of the first calls I got, I think Daniel probably knows this, the people who went to the APAC conference in DC, in which there are about 15,000 people that go to that meeting. Shortly after that meeting, 1 or 2 of the attendees, the famous initial outbreak in New Rochelle, New York, which actually where my sister lives, came down with the disease and reported it back to the organizers. At the time, these individuals did not have any symptoms. And for most people, the most symptoms they may have had is if they passed them going from one meeting to the other. That's not a contact. And the way this disease is transmitted and the way the CDC defines a close contact is if you're within 6 feet of someone where neither of you are wearing a mask and you're with each other for at least 10 to 15 minutes within that 6 feet space. That's considered a close contact. Other contacts would be if someone coughed or sneezed on you, of course, because that's obviously a high volume type of thing. So that's how we think it's primarily spread, and talking can generate droplets. The next thing you've probably heard is there's a number of people that are asymptomatic and may never develop symptoms. So there's 2 terms to think about. One is the individual who gets infected and never develops any symptoms. The other is individuals who may be asymptomatic at day 4, but develop symptoms at day 6. We call that group pre-symptomatic, and it's useful for terms to think about asymptomatic and pre-symptomatic. It appears that there are some asymptomatic individuals who can transmit COVID to other people by close contact. So you need to keep that in mind. We think that the totally asymptomatic individuals are less likely to transmit than those that are symptomatic, but just keep that in mind. Virus also can be shed a couple of days before a patient develops symptoms. Now that's sort of similar to measles and sort of similar to influenza, but for the original SARS, there was no virus shedding until you develop symptoms with SARS, and the peak virus shedding was actually at the end of the first week. The peak virus shedding with this virus is in the first 2 to 3 days. So that's why I'm saying these 2 viruses act very, very differently. The next thing to consider is what about inanimate objects, what we call fomites. If you watch that beautiful video that Shalom Austin produced when they opened about, if you haven't seen that YouTube, it's really worth looking at. It's really well done. They talk about wiping down frequently touched surfaces. And I think that's important, although we don't think that surfaces are nearly as important as droplets. If it's heavily contaminated and it's been freshly contaminated with virus, you can touch it with your hands, and then if you don't wash your hands and touch your mouth and your face and your eyes, that's another theoretical way in which this virus can be transmitted, but not as effectively as with droplets. Now, we've also learned a tremendous amount about this virus, about the symptoms. So in the initial thought, as you probably all know, the main symptom was flu-like. You had a dry cough, you had a fever, maybe you had a sore throat. And that was the primary way we would recognize the symptoms. We now found out that this virus can basically invade every organ in the body. Some people present primarily actually with gastrointestinal symptoms. Some people might present, in fact, my son told me about a case called the COVID toe, very painful, severe toe, because there's a blood clotting problem that occurs with this virus causing these what's called microthrombi and large vessel thrombi. So we got wind of this in February and early March when people began to report that patients who had this disease were getting clots in their leg at a rate that was much higher than they expected. Again, the science has evolved. This is what's really important. The science has evolved that we know how to prevent this. We now know there's a coagulation problem. We now give all patients admitted to the hospital who are diagnosed with COVID, we give them something to prevent them from clotting. There's also neurological problems. Some people actually present with strokes, really young people, very, very impressive. And the other thing we found out is the loss of taste and smell. And in some people, that may occur earlier on, even before they develop symptoms. And again, that's involving neurological. It's the olfactory nerves in our nose and taste that actually gets involved in that. So it involves almost every organ system that you can think of, including the kidneys. Some of our patients who are very ill, their kidneys shut down. So I think it's important to realize this is an incredibly diverse disease. Almost every organ now has been implicated to be infected with this particular virus. The other part is the heart. They can get an inflammation around the heart, so-called myocarditis. So really an impressive array of symptoms that can occur. So the good news is that we've learned an awful lot about this virus, and we've learned how to treat it much better. From how we oxygenate patients, how we keep them off ventilators. Used to be that if patients were increasing their oxygen needs, we would go and put them early on respirators. We don't do that anymore. We treat them with high flow, humidified oxygen, and then we actually prone patients. So prone means most of us are laying on our back when we breathe. We flip patients over. And that improves the spaces inside the lung to allow better oxygenation and better lung compliance. So we've done this on ventilators for a long time for people who have terrible oxygenation who are on ventilators. We're now doing that for patients who are not on ventilators. So we're giving them this high flow oxygen. We're having them on their stomach as much as they possibly can. And so we have prevented, I would say, at least half of the patients that ordinarily would have gone on ventilators just because of good oxygen management. We keep people from clotting. We now have a couple of different interventions that at least are partially effective. You've heard of the antiviral called remdesivir, which is now available by allotment, which we're using quite a bit of. You probably heard about convalescent plasma. So those patients who have recovered, who have high antibodies, we harvest their plasma and give it to patients. We have a couple of other therapeutic interventions as well. And one intervention that's becoming used more often are steroids. Steroids were contraindicated for the old SARS, but it appears that steroids have a role in trying to reduce inflammation, because this is the thing that really kills these patients. They get this tremendous inflammatory response in multiple organs, and especially in their lung, the so-called cytokine storm. And steroids and another particular drug may have a role in trying to calm down that inflammation. I'm going through all this because I want to tell you that the mortality rate from this virus in the state of Texas has reduced by 40%. Now that's huge. There's no question we're seeing more cases. And one of the parameters I look at is not how many positive tests, because testing's become more readily available. I look at new hospitalizations. And I can tell you in Houston, I know it's a slight increase in Austin, but in Houston, there's a huge increase in hospitalizations in the last week to 2 weeks. And that trend, unfortunately, is continuing. I hope it's going to level off soon. It has not overwhelmed the capacity of our hospitals, by the way, but I just wanted to let you know that that we're going to manage this. and we learned how to manage these patients much, much better, reducing their mortality. Now, one other concept you probably heard about the concept of flattening the curve. Remember that old term, flattening the curve? And the purpose for flattening the curve was really to try to help the healthcare system to make sure they could handle the capacity. You know what happened in New York. And so that's why those shelter-in-place orders went into effect, where they really didn't want you to go out except for absolute necessities. That was in effect until Governor Abbott, as you know, began to open up the state of Texas. But that did flatten the curve. Now, flattening the curve does reduce the initial burst of infections, but as you can see, as we've begun to open up society, it's expected that we're going to see some increase in cases over time as people begin to get out, and because we don't have any herd immunity. So we've taken a big spike to what New York had, we've flattened the curve, but we're actually, if you look at the numbers, we're having cases that are going to extend much longer. New York went up and they've come down significantly. If you look what happened in Wuhan, China, they went up and they came down very, very quickly. We didn't have the big spike. We were more of a slow, gradual down. Now we're seeing a spike. We're not overwhelming the healthcare system. We're still okay. And I'll come back and tell you why I think we're having the second spike. It's not the second wave, by the way. But we're really spreading out cases over time, okay? So we are obviously reducing certain transmission, but the whole purpose of flattening the curve was to make sure our healthcare system could handle the increased number of cases. Now, as I look forward to the fall, I don't have a crystal ball. There's a couple of different models. One model says we may have a big second wave like the 1918 pandemic, which was worse than the first wave. That may occur in the late fall, like November, December, which is why a lot of schools like the University of Texas and others are going to have school earlier and let out at Thanksgiving. That's one of the rationales for having that term, okay? The other curve says we're going to have little blips up and down like we're having in Houston and San Antonio and Dallas and to a less extent Austin, but we're not going to have that big second wave. The third is a slow burn. We're just going to continue to have ups and downs, but very, not a big spike, but this is going to be a slow burn until either we get enough herd immunity, which by the way will take years, or we get an effective vaccine. So that's what I think you can look for. Now, I also want to manage expectations. You've heard an awful lot about vaccinations. I must tell you, it's very impressive to see how fast things are moving forward. There'll be what we call some phase 3, which is human testing that may take place fairly soon. Multiple different targets looking at different vaccines. If any of them do eventually get okayed for administration, there's going to be a prioritization in the beginning. There is not going to be enough vaccine for the general population. So I want to make sure. So maybe later this year, maybe early next year, healthcare workers and high-risk individuals may get the vaccine. It was very similar, by the way, to 2009 pandemic when the vaccine became available. It had to be prioritized. But for having enough vaccine for the general population, and I could be wrong, and I hope I am wrong, it may not be till the end of 2021. So we've got more tools to treat the disease. We've learned a lot more about how it's transmitted. And so I think and the healthcare systems are much better prepared. We have much more personal protective equipment than we had before. I can tell you, the supply chain was broken. And still we have some problems with supply chain. The other thing that has been almost fixed is testing. You know how bad the testing was in the beginning. This was one of the unfortunate missteps from the CDC, which generally does a very good job with giving primers and providing them to states and local health departments. As you know, the original test kits were contaminated and they had to have been recalled. That set us back a month. And then we allowed through the FDA to have other platforms for testing other than the CDC platform. And now pretty much anybody who wants to get tested can get tested. So that's one thing I think it's been fixed. The second thing that needs to be fixed is investment in public health. So the NIH has had some pretty decent funding in the last 10 years. The CDC has been pretty much flat. Our local and state health departments, let me tell you, as Daniel says, I have a relationship with our health department in Austin. They don't exactly have a lot of money. They get by with the minimum that they need, with some incredibly talented and dedicated people. The same thing here in Houston. We have a county health department and we have a Houston health department. We have a very, very large laboratory in the Houston health department. They need more people, and what they really need, and they're beginning to hire, are contact tracers. So that's going to lead me in to where we need to go in the future so we can live and manage this virus at a low enough level so that we can get, I'll say, partially back to what I consider the new normal, okay? I think Governor Abbott went a little too fast in opening up Texas. I wish he hadn't gone to phase 3. Having said that, we are where we are, and I doubt we're ever going to go back. I think that's it. There are some negative consequences, by the way, to the lockdown. It's not just about COVID. People who had heart problems, chronic conditions, didn't get health care. When they finally got health care, they arrested before they could get to the hospital and they died. Mental illness, alcoholism, domestic abuse, immunizations went down significantly, and by not only just the United States, but the world. So there are negative medical consequences to the lockdown. We have people, large numbers of unemployed, people that feel desperate and depressed. So we've got to figure out a balance, how we can manage the virus and get to some degree of normalcy. It may take us years to get back to the way things were. So how can we manage? As I mentioned, public health plays a big role. 1, we need to have adequate testing, which I think we have. 2, we need to have contact tracers. So if you identify a case, like someone comes into our hospital from a specific community, we want to collaborate with the health department to get a contact tracer out where they live and make sure that people are tested and that the population understands how to prevent a disease. What's happening in Houston, and it's not just Houston, the Hispanic community is getting killed. They have a different culture, they have a different language. We have to learn how to reach this population in a different way. And right now we haven't had the people, the boots on the ground to go out there and help them to minimize disease transmission in that community. I think we're going to get there by the fall, but it's going to take a little bit more in terms of contact tracing. When we have the testing, we'll be better off in terms of contact tracing. We also understand how to prevent transmission between us. And I think social distancing is here to stay, guys. It really matters. And the other thing is masking. And I hate to use the word mandatory, but I'm going to mention it. It'll never happen from the state level. I have a funny feeling the county commissioner here in Houston might, because Abbott's going to allow some flexibility for local municipalities to do certain things. It's just like immunizations, I'm afraid. If we did not mandate that children were immunized before they went to school, what do you think our immunization rates would be? It would be much lower than it is, and we would still be having vaccine-preventable diseases in this country, like we're seeing outbreaks of measles when we let our vaccination rates decrease. We don't want to go backwards. So I think you've got to wear the mask. The mask prevents us from developing droplets that may get in the air that may infect you. So the way my philosophy is, if I wear a mask, I protect you. If you wear a mask, you protect me. And I'm delighted to see the huge drive of people getting on the HEB website, because HEB backed off its policy. And I honestly, for this, I just don't understand why. 27,000 people within 1 or 2 days got on the website asking HEB to mandate that people wear masks in their store. We've got to do this. If you cannot social distancing, especially if you're inside, you've got to wear a mask. It's really not that big a deal, folks. I have to get a mask when I go into the hospital. I have to wear it the whole time I'm in the hospital. And I've learned to deal with it just fine. A lot of people are responsible. Our culture in this country is not like Asia. But we've got to change that culture, and we have to be considerate of one another. And I don't want to use this term as a political term, but we need to take personal responsibility for our community. And one way to do that is to social distance, to wear a mask. Don't come to work when you're sick. Wash your hands. You know the whole thing. Actually, what we preach, by the way, every respiratory virus season certainly applies for this particular virus as well. So we can manage this if we all work at it together. There are things we do in terms of how you open up an office, how you open up the J. All these things are beginning to occur. How we open up our congregations. We've all been having Zoom Shabbats, right? Actually, I was sort of kidding about it, but I haven't missed a Friday night Shabbat since this started, because I can wear jeans and I can sit in my living room and watch Shabbat services. When it starts over again, I'm going to have to get dressed. So it's going to be a little bit more difficult. But in all seriousness, I think we have to learn to live with it. And we will develop policies that will be as safe as possible. There may be certain things that we're not going to be able to do. So I'm going to end with what I call the 4 C's, okay? One is contact, and that gets to mask and social distancing. The second is confinement. As you know, the indoor spaces are much more conducive to transmission than the outdoor spaces. So it's really important that we work in the indoor. There's things you can do, by the way, with your air conditioning system, your outside air exchanges and your filters that can make it much, much easier. The next one's going to be crowds. And, you know, we know about crowds, we hope we don't see a blip with these demonstrations that have occurred in the last couple of weeks. A lot of people were wearing masks and it was outdoors. I only hope we don't see a blip in that. And the third one is choice. And I think this is important. Our high-risk individuals have to be aware of their risk factors. We have to advise them about what situations may be safe or not safe. And it ultimately is going to be their choice, whether they come into our congregation, whether they come into our space. But we should be very sensitive that we don't want to expose our high-risk individuals. Now, people living in nursing homes, et cetera, you know, they've been in lockdown for quite some time, because when this gets started in nursing homes, I would say, I think 1/4 to 1/3 of the deaths in this country have been in nursing homes. So there's a very strong policy now about testing, visitations, et cetera, because we've learned a lot. We certainly don't want to hurt our most vulnerable. So I'm going to quit there, and I think Daniel's going to try to screen the questions, and I'll see if I can answer them. But I hope that's useful information. I want to put it in the context about how we can do this. I really am cautiously optimistic we can manage this, but the virus is not going to go away.
Right. Well, thank you. That was really thoughtful, meaningful, and well done. And I'm not prejudiced as my grandma.
No.
So first question that Sandy Dochin wrote is, and you alluded to this when you were speaking about the policies coming from the state and the governor's office, but if you had 30 seconds to ask Governor Abbott a question or offer some advice, what would you say as a medical expert?
What I would, and he's got some medical people around him, and I know that he has to balance the medical and the political and the economic, okay? But I would say, I would go back to looking at how we prevent transmission, some simple common things, such as, don't you think we ought to mandate masks if social distancing is not possible? Making sure we set up areas that it's easier to social distance, avoiding crowds, making sure we have hand sanitizers, disinfection of the environment. But I think the single thing he could do, and I think he's sort of beginning to loosen up on that, is let the municipalities actually increase things like masking if it's based on their local caseload. You know, the state of Florida, I think, did it pretty smart. They opened up the northern part of Florida, but Dade County and Broward County, which is Miami and Fort Lauderdale area, they had a lot of cases. And so the governor eased up on the northern side, and then he still kept the shelter in place in southern Florida. I think that's the way we should go. We should have some general guidance, but there should be some flexibility locally, and I wish they would make a strong statement about masking.
Thank you. So speaking of crowds, Ian Stuckler is asking, if social distancing is here to stay, when do you see us doing any of the following? One, attending a Longhorn, or I will add Texas A&M football game, or any football game, attending a concert, or three, attending a religious service, Shabbat or high holy days, etc.
Okay, well, the easier one is Shabbat services, believe it or not. It depends upon your physical setup in your synagogue. So as Daniel knows, we have the two large Reform synagogues and the largest synagogue in town, the conservative synagogue, have very large sanctuaries. And so depending upon the event, some life cycle events would have to be taken into account, they can develop a policy to develop pods of social distancing throughout their sanctuary, so they maintain social distancing, making sure that people wash their hands when they enter, they don't have any symptoms, and that they wear a mask. And so it means that you may have to limit the number of people that come into your space, and you need to have a flow. They come in one way, they leave the other, so that people are not crossing each other. I mean, it can be done, but it has to be thought of very, very carefully, and you have to enforce the masking policy. If you have a chazan, that presents another interesting challenge, because singing is one of the best ways to develop droplets. There's ways to do this, either by putting the chazan up high and physically 10 to 15 feet away from everyone, or because most of them use wireless mics, potentially you can put up some plexiglass in appropriate places. So I think that's to me, Louisa. Now, the high holidays, guys, that's going to be another very difficult decision that your congregations are going to have to make. Obviously, you're not going to have you cannot have high holidays the way you remember them for the next year or two. You can't jam everybody into the sanctuary where it depends upon the size, but you'll be shoulder to shoulder. That's the time that people come to services. So you have to figure out another way. Either you limit the number, or you literally go to Zoom services, but it's from the liturgical staff does it from your sanctuary. But you're not going to be able to have the numbers at the high holidays that you inspected in years past. And whether or not you don't allow anybody, or whether or not you have a system that you have limited number of people that come in, that's going to be a local decision. But I think that's one. As far as concerts are concerned, indoor concerts, I think that's going to be, I don't see that happening. I don't know about going to the symphony, going to the ballet, going to the opera, where you have 2,000-3,000 people. I don't know how that's going to work in the fall, and many, I suspect, are going to be canceling their fall season. That's my suspicion. Now, in terms of a Longhorn game, which I know I can see that Ian is really a big fan, hook 'em horns, right? My undergraduate, by the way, was Ohio State, but I don't want you to feel so bad. Texas A&M, and I'm not trying to pull one Texas team against another. They actually came up with a seating arrangement in Kyle Field that could accommodate that, but they would only be able to have 25 to 30,000 people in the stands. That's theoretically, if they could do it that way, that's there. But in terms of having 100,000 people, I don't think that's going to happen. As you know, we may not have a baseball season this year because they can't agree financially. And because of the infection rates that are going on around pro football, I don't know about pro football season either. But if they do, they're going to have the U.S. Open tennis tournament is going to take place, and it's going to take place in empty stands. So, in answer to your questions, if it does happen, it's going to be limited number of spectators or no spectators at all, especially for indoor events. Outdoor events, maybe you can do something that can be, I think, medically prudent. But I think it's going to be a while before we have big crowds like that.
Thank you. Your other son wants to know if you think children can or should be expected to wear masks when they go back to school. I'll actually add when they go back to day camp, because some, obviously like us, we're starting July 6th, but get your thoughts on that.
Well, that's a great question, because children go across a number of ages. So as you know, no child under age 2 should wear a mask, and that's a safety issue because they can suffocate. The governor's guidance, if I recall, is greater than age 10, as I remember his guidance. The CDC guidance also agrees not less than age 2, and says if the older child can wear a mask, to wear a mask. So between age 2 and 10 is sort of a gray area. I think if they become teenagers, like if you're going to go to junior high or high school, I think you're going to see most of the schools require their students to wear masks. But the younger children, maybe not so much. Depends upon how old the child is, because they're probably not going to keep the mask on is the problem. But over age 10 or 11, they probably can. CDC says if you can get younger kids to do it, fine. But I suspect it's going to be difficult for children to do that. The other good news is that children, as I already mentioned, are A, less likely to get infected, and B, if they do get infected, they have much milder illnesses. But I will say they can transmit, especially if you live in a multi-generational household, they can transmit disease to household contact. So I don't want to be glib about, children, you don't have anything to worry about. It's like our teenagers and our young adults. They go out on the beach and they party and they think they're invulnerable. The problem is, I can tell you, in terms of our hospitalization ages, it actually starts at age 20, 25, and actually the majority of hospitalization between age 25 and 60. Okay? So younger people can get very sick with this disease, and they shouldn't take it for granted, even though they're less likely to die from it.
Right. Thank you. So Alan Zimmerman, you were speaking earlier about infection rates in the population, and he's wondering, how do we know the percentage of the population or estimated percentage that has been infected without wide antibody testing?
That's
antibody testing.
Well, that's how these big studies were done in San Jose. The one that was actually just published, by the way, in New York, where they found that the infection rate by antibody test was about 20%. In places like San Jose and elsewhere, it's much less. So the way to do it is, has been alluded to, is serological testing is the best way to see what percentage of the population has been infected. And what you'll find, as these other serological studies have found, that the number of people that test positive by the traditional nasopharyngeal PCR test, that represents a very small fraction of the total number that are actually infected. Now that number, by the way, is changing because we have far more availability. We used to prioritize who could get tested. We don't prioritize anymore. So we're getting far more people tested. So we're beginning to pick up people that we didn't pick up before. But nonetheless, the most accurate way is to do it serologically. And again, that's why I'm telling you, far more people have been infected that know it. That's why the fatality rate is much lower than was originally reported.
Right. Thank you. So Steve is asking a question about the level of risk from sitting on a park bench. And then he also asked, there was some conversation about the virus as the summer season arrived and the temperatures increased, that direct sunlight might disinfect surfaces and railings and things like that. So if you could just comment on maybe the seasonality of the virus and then also the effect that the warmer temperatures have on disinfecting surfaces and the transmission in general.
First of all, it's a new virus, so anything I say now is based on what limited data is available. Obviously, we're in the warmer months, and Houston and Texas are seeing increased numbers. The state of Florida, since they've opened up, have seen increased numbers. So we don't know enough about this virus to be absolute. It is true, though, that warmer temperatures, more humidity, and direct UV light does have an impact on the amount of virus which is out in the environment. So you mentioned about being on a park bench, okay? I already mentioned that the inanimate objects or the fomites probably are not as big a way to transmit disease. So you would have to have someone who was actively infected, contaminate the surface, have enough virus that's actually alive. You would have to touch it and have enough virus on your hands to contaminate yourself. All those things have to take place. If that bench has been vacant for a while, as an example, and the sunshine is on it, I can guarantee that the virus is going to degrade very, very quickly. The one thing we don't know, which I wish we did, is how much virus does it take to cause infection? Do you need 1 copy? Do you need 100 copies? Do you need 10,000 copies? We don't know. But the amount of virus that are on surfaces is fairly low. It may or may not be actually alive, and it may or may not be high enough load to cause infection. So the CDC, I think, appropriately has revised its statement saying that fomites are not nearly as risky as droplets. But nonetheless, you still wipe down the high touch areas frequently and do a thorough disinfection, especially at the end of the day. And I know what you're doing in Shalom Austin. You're actually closing down places for a short period of time and using a much stronger way to disinfect the environment. So it's a good idea to disinfect the environment, but I want to let you know that you still ought to pay attention to droplets.
Great. And then the last question here, it looks like possibly for the evening, and Sandy's asking it again, is if you have any additional advice for the baby boomer slash or aging boomer types, as he put it, and high-risk folks.
You mean, what do we do as us baby boomers in terms of what we should do?
Yes. Any additional advice for your generation?
Well, I think you should be, here's some things I'd recommend. One, you should avoid crowds, okay? Second, you should try to make sure that you practice social distancing and wear your mask. I think that's very important. You want to stay away from people that are ill. So I think you just want to do things that don't put yourself at greater risk than just the day-to-day living. Now, if you're in a nursing home, it's a whole nother, that's very, very different. We're talking about, he's talking about ambulatory baby boomers who still can get up and maybe play golf, et cetera. Golf is fine, it's outdoors, et cetera, but just don't get involved in areas where there's crowding, especially when people are not practicing social distancing and are not wearing masks. Sort of scope out those things. Those are kinds of things that I would avoid.
Right. Well, I want to thank you, and I'm going to turn it back over to Shana to have the final word, but thank you so much for joining us this evening. It's always nice to see my father teaching, which I rarely get to do, actually. Whenever I ask him for information, I don't get a thorough lecture. I get like a snippet. So this is the only way I get to hear everything.
I want to know who Shana's assistant is.
My daughter?
Very, very cute daughter.
Thank you. Thank you very much. This was absolutely wonderful. I appreciate, again, everyone being here. Dr. Septimus, thank you for your wise wisdom. Amazing. I'm gonna let Ian close us out tonight, but yeah, go ahead, Ian.
I totally echo that. It was fantastic.
Go Buckeyes, right, Ian?
We had a great home and home with the Buckeyes in the mid 2000s, but anyways, we could talk Longhorn football.
I think the Buckeyes have won a few more national championships since then, but okay.
But thank you so much, Dr. Septimus. That was wonderful. Thanks so much, everyone, for being here. Please stay tuned because David and Sandy Dochin and I had an outstanding meeting on the future of Supper Club somewhere around February 20th. And we had an amazing meeting and had amazing ideas about awesome things that we were going to do. And then Dr. Septimus just trampled over all of our ideas. But we are going to have more events this summer. So please stay tuned and please do attend because this is a great way for us to get together and have some great conversations as a community. So thanks a lot. Have a good night, everyone.
Thank you again.
Everyone.
Bye-bye.
Shabbat shalom.
Yeah.
Shabbat shalom, everyone.
Thank you.
Bye. Thank you.